Testing. Okay, great. Okay, great. Okay, so please give me a second to prepare material. Let me I just read this. Okay, so last se- okay. So last time we read the renal physiology, ECF and ICF. ECF is a 1/3 and ICF is a 2/3. ECF extracellular fluid. Which we have extracellular fluid of two compartments. It's a vascular, which is a 1/3, interstitial, which is a 2/3. Okay. So that's just 1/3 and 2/3 of 1/3 of extracellular fluid of the body fluid. Okay, and ICF is 2/3. Now, if how many liters of isotonic saline do you have to infuse to get 1 liter into the plasma? So 1 liter into plasma, which is plasma vascular. If 1 liter, then interstitial, which is 2 liter, because it's 2 times. So then the totally extracellular fluid, which is 3 liters. And then we need to do this 3 liters. So osmolarity measure absolutes in fluid due to 3 things: sodium, glucose, and BUN. So blood, urea, nitrogen. So urea cycle is located in the liver. So partly in the cytosol, and partly in the mitochondria. Usually multiply sodium times 2 because of 1 sodium and 1 chloride. So fluid and hemodynamic. So normal sodium is a 135, 140 range. So times that by 2. So that is about 280, which is 140, which is 280. So for glucose normal, which is 100, divide that by 18. So then let's say 18, which is 20. So 100 by divided divide that by 18, so equal 5. So let's say it's roughly 5. So does not contribute much. BUN located in the liver. Part of the cycle is in the cytosol and part of it is in the mitochondria. The urea comes from ammonia. That ammonia is gotten rid of by urea because the end product of the urea cycle is urea. The normal is about 12, divide that by 3, so we have 4. Therefore, in a normal person, sodium is controlling in plasma osmolarity. To measure serum osmolarity, double the serum sodium and add 10. So osmosis. Two of these three are limited to the extracellular fluid compartment. One can equilibrate between ECF and ICF across the cell membranes. Urea, therefore, with the increased urea, it can equilibrate equally on both sides. So it will be equal on both sides. This is due to osmosis. Because sodium and glucose are limited to the extracellular fluid compartment, then chances in its concentration will result in the movement of water from low to high concentration, opposite of diffusion. For example, in lungs, 100 millimeter mercury in alveoli of oxygen, and returning from the tissue is 40 millimeter mercury PO2. 100 versus 40, so which is bigger? 100 is bigger, so via diffusion, the oxygen moves through the interspace into the plasma to increase oxygen to about 95 millimeter mercury. Therefore, in diffusion, it goes from high to low, while in osmosis, it goes from low to high concentration. Example, in the case with the hyponatremia, water goes from ECF into the ICF. So give me a second. Water goes into the ICF, and therefore, so in case of hyponatremia, which is low sodium hypotonic, in the bloodstream it's low sodium, so then the water have to go from the inside vessel to get out, so get into the inter interstitial space. Water go from ECF into the ice. Low sodium so which is get into the cell, right? So with the hyponatremia, which is a low sodium in the bloodstream. So remember, bloodstream is vascular. So this low that which does belong to extracellular fluids. So then if low sodium in extracellular fluid, so then water, so we will go from the ECF get into the ICF and make the cell swollen more, right? So that's why make the cell get into the intracellular fluid, so inside the cell, so make the cell swollen. Right. You remember the frog experiment on the frog in the lab? If we put the frog in the water, but water which is hypertonic, is more sodium there, more sodium, and then they suck the water uh, inside of the frog get out, you know, so get into the water of the pot. So that's why I make the frog is a shrunken skin, right? Kind of like that. And in vice versa, if we put the frog in the hypotonic fluid, which is a low sodium environment, so then the frog suck the water so from outside, so get into their body. So then after that, the frog gets bigger size gets swollen. So the same concept here. In case it's a low sodium in the bloodstream, which is a hypotonic uh, in the bloodstream, which is the extra cellular fluid. So which is low sodium there. So which is inside the cell, which is becomes is a high sodium there. So they suck the fluid from outside the cell get into the cell, so the cell get swollen. So water go into the intracellular fluid, and therefore, so they expanded by osmosis. Now make believe that the brain is a single cell. What we see so causes cerebral edema and mental status abnormalities via law of osmosis. Intracellular compartment and all the cells of them would be expanded. Okay. Now talk about the hyponatremia. Now, so which is a high sodium in the bloodstream. So this bloodstream this belong to the extracellular fluid. So then if like that, then they suck the water inside the cell, get out of the cell, so get into the extracellular fluid. So that make the cell this shrunken, and but make interstitial space swollen, and make the inside the the vessel also more fluid there. I think this is cause um, hypertension. Water goes out of the intracellular fluid into the extracellular fluid, therefore the intracellular fluid will be contracted. So in the brain, it will lead to contracted cells, therefore mental status abnormalities. So abnormalities, therefore, with hypo and hyponatremia, we get mental status so abnormalities of the brain. So example, DKA have a 1,000 milligram less amount of blood sugar. Okay, so diabetic ketoacidosis, they have a large amount of blood sugar. Remember that both sodium and glucose limited to the extracellular fluid compartment. So you would think that glucose is in the intracellular fluid, but it's not. You think that since glycolysis occurs in the cytosol, therefore, so glucose in the intracellular fluid. Again, it's not, because to order to get into the cell, intracellular glucose must bind to phosphorus, generating GCP, which is metabolized. So this is the same with the fructose and galactose, which are also metabolized immediately. Therefore, there is no glucose, fructose, or galactose per se intracellularly. So with the hyperglycemia, which is high glucose in the bloodstream, so there is high glucose in the extracellular fluid. So water will move from uh, intracellular fluid to extracellular fluid. Therefore, the serum sodium concentration will go down. That we call this a dilutional hyponatremia, which is what happens to serum sodium with hypoglycemia. In the patient with high glucose in bloodstream, then they suck the water. So from inside the cell get into to bloodstream, which is extracellular fluid. So get into bloodstream, and then they get there. See, that's why they make the sodium kind of so become low is because of more water in the bloodstream. So that's why they call this condition they call dilutional hyponatremia. When we see hyperglycemia, then we saw the hyponatremia. Therefore, the two things that control water in the extracellular fluid are sodium and glucose. So, but a normal situation, sodium controls. Therefore, the two things that control water in the extracellular fluid it is sodium and glucose. But in normal situation, the sodium control. But if some kind fluctuated situation, then two factors control water in the extracellular fluid, which is sodium and glucose. So, and how about BUN? Urea does not control water movement because it's permeable and can get through both compartments to have equal concentrations on both sides. Now tonicity, isotonic state, hypotonic state, and hypertonic state. We have all different types of saline, isotonic saline, hypotonic saline, half normal saline, quarter normal saline, 5% dextrose in water. That's okay. And hypertonic saline 3%, 5%, and normal saline is 0.9%. We are referring to normal tonicity of the plasma, which is controlled by the sodium. These are the three types of tonicity: iso, hypo, hyper. Serum sodium is a reflection of total body sodium divided by total body water. Serum sodium is a reflection of total body sodium divided by total body water. Total sodium divide total water to equal this serum sodium. For example, hyponatremia, which is high sodium in bloodstream, is not just caused by increased total body sodium, it can also caused by decreased total body water. I think makes sense. But because we know the formula, that's why we say makes sense. But let's say now, if let's say we say like that, if the total body sodium increase, then we know so possibly so increase sodium in the bloodstream. Yep. But if now low water, right, then condense more, so then the sodium in bloodstream high. Yeah, because divide by water. Ma. Okay, now clear now. It's really the ratio of total body sodium, total body water. To determine sodium, just look at serum level with different fluid abnormalities. Abnormal, abnormalities. Abnormalities can lose again the certain tonicity fluid. So yeah, with the different fluid abnormalities can lose again. Okay, okay. Isotonic loss of the fluid. Look at ratio total body sodium and water. In this case, you are losing equal amounts of water and sodium. Losing equal amount of water and sodium, so then we call isotonic. This fluid is mainly lost from the extracellular fluid. This, this extra because in bloodstream, total body total body water include the two compartments which is extracellular fluid and intracellular fluid. And remember extra fluid, we have two subcompartments which is inside the vessel and interstitial space. The serum sodium concentration is normal when loose in isotonic fluid. Extracellular fluid would look contracted. There would be no osmotic gradient moving into or out the clinical condition where there is isotonic loss of fluid, which is hemorrhagic or diarrhea condition, you know, hemorrhag hemorrhagic condition. That's a we lost it, the extracellular fluid. Diarrhea also lost extracellular fluid. So if we have isotonic gain, we have equal increase in salt and water. Talk about isotonic loss and talk about the isotonic gain. We have equal increase salt and water. Some getting too much isotonic saline. Normal serum sodium. Excessive isotonic sodium would be in the extracellular fluid, and there would be no osmotic gradient water movement. No osmotic gradient movement. So in both conditions, because isotonic, so no osmotic gradient movement. The reason because if they lose, both lose. If they gain and both gain, which is isotonic gain, isotonic loss, which is lose total body water and lose total sodium. Isotonic gain, which is increase both, which is total sodium and increase total water. Now talk about hypotonic solutions. By definition, it means hyponatremia. So hypoglycemia will not produce hypotonic condition. Right, let's say if hypoglycemia, which is low sugar in the bloodstream, so which is extracellular fluid, if low like that, then what? And then the intracellular fluid, which is inside the cell, high sodium, which is they suck the water from the outside the cell get into the cell to make the blood volume reduce. When the blood volume reduce, which is the increase the sodium concentration in the bloodstream, so they cause a hypernatremia. You know, if a low sugar, then high sodium, low sugar in bloodstream, then high sodium in bloodstream, and in vice versa. Okay. Oh, what they say hypoglycemia will not produce the hypotonic condition. Oh, hypoglycemia will not produce hypotonic. They cause a hypotonic or not? That's my question. But let's say we're different. Most common cause of low osmolarity in plasma is a hyponatremia. How? Lose more salt than water. Therefore, serum sodium would be decreased. Huh. If losing most common losing more salt than water. Kidney is probably the location where what's happening. Main place to deal with sodium, either to get it off it or to get it back. Is the kidneys, especially when dealing with diuretics, furosemide and ICTC. The tonicity solution you lose in your urine is hypertonic, so that how you end up with the hyponatremia with the hypotonic condition. So ECF concentration is low with the hyponatremia. Therefore, the water will move into the ICF compartment. Oh, anyway, you read the example. If you get pure water and no salt, then you have really low your serum sodium. Yeah, correct. Most common cause is SIADS in small cell carcinoma of the lung. Like that. Example, gain both water and salt, but more water than salt, then lead to also the hyponatremia. So these are the pit in edema stage, renal right heart failure, cirrhosis. When total body sodium increase, it always produce a pit in edema. Both again, gain water, but gain salt as well, but gain water more. So then because gain water more, then they cause hyponatremia. When hyponatremia, uh, so see in the right heart failure, cirrhosis, when total body sodium increase, it always produce a pit in edema. What compartment is total body sodium in? Oh, the compartment total body in which is extracellular fluid. What is the biggest extracellular fluid? We know interstitial space already. Therefore, increase in total body sodium will lead to expansion interstitial compartment. So water will follow the sodium, therefore you get expansion via translate and pididinema, seen right heart failure and cirrhosis. Okay. Example, hypertonic loss of salt. So from diuretics leads to hyponatremia. Use diuretic a lot and they cause lost sodium. Reduce blood pressure because this in the SIADS, which again a loss of water, so lead to hyponatremia. Gaining more water than salt will lead to hyponatremia, cause edema. Now talk about hypertonic stage. By definition, have too much sodium, hyponatremia, or have a hyperglycemia. Hyperglycemia, they can cause hypertonic stage. For example, patient with a DKA has a hypertonic condition, which is more common than hyponatremia. With hyponatremia, what does ICF look like? So that look like shrunken, right? It says shrunken. So primary aldosteronism, aldosterone indicate the sodium more, gain more salt and water. Diabetes insipidus lose pure water versus gaining pure salt in SIADH. If you lose more water than salt in the urine, you have an osmotic diuresis mixture. So when there is glucose and mannitol in the urine, you are losing hypotonic salt solution in urine. Example, baby diarrhea. So in which they lost the water and they cause a hypotonic salt solution. And why? And how about the adult diarrhea? Adult diarrhea they cause isotonic, but baby diarrhea they cause hypotonic, which is they lost sodium too. Lost sodium more than water. But in the adult, which is lost both water and sodium, so they cause the isotonic. Therefore, if baby has no access to water and has a rotavirus infection, serum sodium should be high because losing more water than salt leading to hyponatremia. However, Most moms give the baby water to correct the diarrhea. Therefore, the baby will come in with normal serum sodium or even hyponatremia because the denominator, which is water, is increased. Read again. If the baby has no access to water and has a rotavirus infection, serum sodium should be high. If the baby have no access to the water and also have a rotavirus infection, then serum sodium should be high before losing more water than salt. If like that, why the causes leading to hyponatremia? So not sure why beginning they say something really weird like that. Resemble baby diarrhea, but when they said hypo, that's supposed hypo. Anyway, so skip that. So leading to hyponatremia, yeah, because I lose water than salt. So salt is condensed, concentrated. So that's why hyponatremia. However, most moms give the baby water to correct the diarrhea. Therefore, the baby will come in with the normal serum, sodium, or even hyponatremia because give a lot of water, then we see the normal serum, but or even give a lot, so then become more water than salt and become this hyponatremia. So because a lot of water, you know, the sodium blood sodium equal what? Equal total sodium over total water, but now a lot of water, which is denominator increase, so that's why the result which is reduce sodium in the bloodstream cause hyponatremia. Treatment is Pedialyte or Gatorade. This hypotonic salt solution. So beginning did talk about as a treatment. It may be diarrhea, so they use hypotonic salt solution. So give them back what they lost. What has to be in a Pedialyte and what has to be in Gatorade in order to reabsorb the sodium in GI tract, glucose because of the co-transport. With the co-transport, the sodium has to be reabsorbed with the glucose and galactose. Example, uh, cholera, cholera, which is um, diarrhea. So in oral replacement, need glucose to reabsorb sodium because the co-transport pump located in the small intestine. So Gatorade has glucose and sucrose, which is converted to fructose and glucose. Sweat, hypotonic salt solution. If you are sweating in the marathon, you will have a hyponatremia. If you are sweat in the marathon, then you will have a hyponatremia. More salt, then we need to put the with treatment we give the hypotonic salt solution. We technically we give more water. So which we use the cut we use the Gatorade Pedialyte. Now talk about volume components. Arterial blood volume is same as stroke volume and cardiac output. When cardiac output decreases on physiologic So all physiologic processes occurs to restore volume. So with decreased cardiac output, hypovolemia, so oxygenated blood will not get into the tissue and we can die. Therefore, volume is essential to our bodies. We have a baroreceptors, low and high pressure ones. So the low pressure ones are on the venous side, while the high pressure ones on the arterial side, carotid and arch of the aorta. They are usually innervated by nerve 9 and 10, cranial nerve 9 and 10, the high pressure ones. When there is a decrease in the arterial blood volume, so decreased stroke volume or cardiac output, it will underfill so the arch vessels and the carotid. Instead of 9 and 10 nerve response, you have a sympathetic uh, nervous system response. Therefore, catecholamines are released. This is good because they will constrict the venous system, which will increase blood returning to the right side of the heart. Do not want venodilation because it will pull in your legs. So catecholamines will act on beta-adrenergic receptors on the heart, which will increase the force of contraction. So there will be increase in stroke volume slight and it will increase heart rate. So positive chronotropic effect on the heart, increase in systolic blood pressure. So arterioles on the systemic side stimulates beta receptors in smooth muscle. So the systolic pressure is really due to the amount of blood in the arterial system while your heart is filling with blood. Who controls the amount of blood in the arterial system while your heart is filling in that stone? Your peripheral resistant arterioles. So that maintains your diastolic blood pressure. So when they are constricted, very little blood is going to the tissues. Bad news, good news, keep up diastolic pressure. This is important because the coronary arteries fill in diastoles. So this is all done with the catecholamines. Renin system activated by catecholamines too. So angiotensin 2 can vasoconstrictor the peripheral arterioles. Therefore, it helps the catecholamines. Angiotensin 2 stimulates the 18 hydroxylase, which converts corticosterone into aldosterone and stimulates aldosterone release, which leads to reabsorption of salt and water to get cardiac output up. With a decreased stroke volume, renal blood flow to the kidney is decreased, and RAA, which is renin and angiotensin aldosterone, can be stimulated by this mechanism also. So where exactly are the receptors for the juxtaglomerular apparatus afferent arteriole? So there are sensors which are modified to smooth muscle cells. Sense the blood flow. IDH will be released from the nerve response and pure water will increase, but that does not help with increases the cardiac output. So need salt to increase cardiac output. Resemble bleeding to death and there is a loss of 3 liters of fluid. How can you keep blood pressure up if normal saline is isotonic? Therefore, the saline will stay in the extracellular fluid compartment. Normal saline is plasma without the protein. Anytime you have a hypovolemic shock, give a normal saline to increase blood pressure because it stays in the extracellular fluid compartments. Cannot raise the blood pressure with have normosaline or 5% dextro have to give something that resembles plasma and have the same tonicity of the plasma. Normosaline is 0.9%. Maybe we stop right here. Polytubular capillary pressures, you reabsorb most of the sodium in the proximal tubule, 50–80%, whereas the rest absorbed in the distal and collecting tubule by aldosterone. The sodium is reabsorbed into peritubular capillaries. Stalling force in the capillaries must be amenable to stalling force. Oncotic and hydrostatic. Oncotic pressure keeps fluids in the vessel, and hydrostatic pressure pulls fluid out of the vessel. Example: when renal blood flow is decreased. So with the decreased stroke volume and cardiac output, what happens to peritubular capillary hydrostatic pressure also decrease. Therefore, the peritubular oncotic pressure is increased. The force that keeps fluids in the vessel, so that is responsible for reabsorption of anything into bloodstream from the kidney, is why PO, which is peritubular oncotic pressure, higher than pH, which is hydro pressure or peripheral capillary. Oncotic pressure higher than hydrostatic pressure, so allows absorb containing fluid back into bloodstream into the kidney. Okay, let's stop right here.